There's also political factors that we have to consider. Pointer wrote an article for the journal showing how, in the veteran context in the United States, that it was very difficult to request the use of symptom validity testing and to establish the truth value of the complainants who were presenting with post-traumatic stress. And in this kind of work, that is important, but that kind of request led to her dismissal, so she believes. So it's not just psychological and psychiatric injury in law, it's also in society. What about pain? Gatchel wrote an essential article in Psychological Bulletin that we all should be aware of, describing the biopsychosocial nature of pain. Pain is not just a medical condition. Pain involves sociocultural factors, it involves psychological factors, coping skills, uh, pre-existing psychopathology, and vulnerabilities. It involves legal considerations, and all sorts of stress. And it's not a symptom or a condition that reflects a one-to-one relationship to extent of tissue damage. And that is a conundrum, and that makes it difficult for court purposes. And that's why we have to be comprehensive in our assessments in chronic pain and related conditions so that we can understand its dynamics and its validity. Chapman and Sullivan reviewed the literature on the relationship of mood and affect on pain, which I won't review, but briefly, depression, anxiety, stress, including post-traumatic stress, worry, fears, phobias, any type of mood impacts the person's bodily reactions and takes on a bodily component, and therefore are factors to consider in the expression, the propagation, the maintenance, and the expansion of pain in the individual after events I've claimed. One model that is important in this area is called the mutual maintenance model, whereas pain and coexisting mood morbidities such as post-traumatic stress or depression mutually interact with each other. And the more one goes up, it affects the other in a circle that exacerbates both. Right? And in Liddell et al. 2010, a re-experiencing in the post-traumatic stress sense leads to a sequence of arousal, avoidance, and muscle tension, which drives in a vicious circle the pain and further avoidance and further re-experiencing. So this is an example of the mutual maintenance. Otis et al. In 2010 examined the relationship of post-traumatic stress and measures of affective distress in chronic pain patients, also in the same kind of research. And Robinson et al. And O'Brien rather in 2010 argued that pain is multidimensional and includes negative affect, interpersonal factors, and perception of degree of life control as mediating variables in its expression. So there's no simple answer when it comes to pain, and understanding its dynamics and even how to treat it. Nevertheless, Shachtman et al. And Howard et al. With Bob Gatchell being the co-author in both these articles describe a comprehensive muscular activity profile, a CMAP, which might give a biomarker, if you will, of the validity of pain and its expression compared to the invalidity. And we hope that we see more research with that marker, and that it will be useful one day for court purposes. What about traumatic brain injury? Spordone wrote an article about the ecological validity of the testing in this field. For example, executive function, neurobehavioral symptoms, and frontal lobe function might be more difficult to test with standard neuropsychological instruments. And Ruff and Jamora wrote an article on the myths involving mild traumatic brain injury. They had described the miserable minority that can endure post-concussive symptoms beyond the expected date of their disappearance. And that this happens, for example, after motor vehicle accidents. And part of it is that there's mediating factors such as pain, headaches, distress, depression, post-traumatic stress, etc., that get involved in this mutual maintenance between the memory, cognitive, attention, and other related neuropsychological functions, which show decrements after a mild traumatic brain injury, and which do not improve or even get worse due to the interactions with all the mediating variables, despite pathophysiological improvements. Gironda et al. In 2009 found that polytrauma involving traumatic brain injury, pain, and post-traumatic stress is even that much more complicated to treat, and that we need an effective program of intervention. Of course, the cognitive behavioral component to that intervention is crucial. So the mutual maintenance can be involved more than two factors, as this example provides. Schultz looked at the DSM-5, and she noted multiple difficulties with the approach of the DSM-5 to traumatic brain injury. Richards and Kirk in 2010 offered a tutorial on TBI for attorneys. The article is noteworthy for its inclusion in one source, TBI for children and TBI for adults. There are other psychological injury and psychiatric injury conditions that we should be considering, such as depression. For example, Duckworth and Diezi in 2010 and others have examined depression in relation to psychological injury. What about stress? Stress is a common variable in all these conditions, and it plays a pernicious role. There are inflammatory effects of stress that propagate the injury, that produce inflammation. Pro-inflammatory cytokines are involved and are released. There's cortisol responses in stress that is released. And Kendall Tackett reviews the literature related to depression, hostility, and post-traumatic stress disorder, and showing how stress in these conditions can be quite detrimental to the individual. And there's long-term health impacts as well. So our psychological injuries have to be evaluated for things like possible heart disease and long-term pain conditions, impaired wound healing. And this is why we get the course not following the expected improvement pathways that we might otherwise expect. Another important variable to consider is pre-existing psychopathology. It's not that we have to evaluate that when we see our assessees. However, we do have to have literature, the medical documentation, the psychiatric documentation reports available from their past records to establish the degree to which they had any conditions that might be relevant to establishing causality. In law, there's the concept of thin skull and crumbling skull. And thin skull would indicate that the person had pre-existing conditions, but it was not enough to explain the full psychological or psychiatric presentation that is being evident in the person in the assessment and in prior reports that are made available to you as the assessor, whereas crumbling skull refers to the fact that the pre-existing conditions are so severe that it might explain in full or almost in full the presenting problems that the person is displaying to you and has been reported in their other reports.